Welcome to the Deep Dive. We're here to unpack complex texts and pull out those crucial insights you need. Today, we're taking a really close look at post-traumatic stress disorder, PTSD. It's classified in the DSM-V under trauma and stressor-related disorders. And when you read how the source material describes what it's like to live with PTSD, I mean, the language is really striking. It's not like remembering something bad that happened. People actually relive distressing instances of the traumatic event with vivid emotional proximity. That's a direct quote.
It is, and there's another phrase they use for, say, someone traumatized in combat, the war never ends. It really paints a picture.
It does. Their whole life becomes this constant effort to dodge reminders. But at the same time, they're always on edge, hyper alert. The text says tense, restless, and exhausted.
And that phrase, the war never ends, it perfectly captures what makes it post-traumatic, doesn't it? The core issue is that these symptoms stick around long, long after the actual danger is gone. And what really sets it apart from just, having bad memories is that it's involuntary. It's uncontrollable. The person isn't choosing to remember. They're being pulled back into it, feeling it like it's happening right now.
That difference remembering versus actually reliving feels critical.
Nah.
So, okay, our goal today is to walk you through how psychiatry structures this disorder. We'll cover the diagnostic criteria, the history behind the label, and what the evidence says about treatment, all based on this foundational text.
That's good.
Let's start with what makes PTSD diagnosis kind of unique in the DSM.
Okay.
Unlike, say, depression or psychosis, where the symptoms are the disorder, pretty much,
Yeah.
for PTSD, you have to connect the current symptoms back to a specific trigger, a traumatic event.
Exactly. That's criterion A. It's the gateway criterion, you could say.
And criterion A isn't just any stressful event. It's a high threshold, right?
Very high threshold. It involves exposure to actual or threatened death, serious injury, or sexual violence. And the source outlines 4 main ways this exposure can happen.
What are they?
First, the most obvious one. You experience the traumatic event yourself, directly.
Makes sense.
Second, you witness it in person, happening to someone else.
Okay.
Third, you learn that it happened to a close family member or a close friend. But there's a key detail here. If it involves death, it has to be violent or accidental.
So learning a grandparent died peacefully doesn't count for criterion A, but learning they died in, say, a sudden violent accident might.
Precisely. That distinction is important. And the fourth way is about repeated or extreme exposure, usually in a professional context. Think first responders arriving at horrific scenes again and again.
Or police officers dealing with graphic evidence, maybe.
Exactly. And this is a really important exclusion. The text points out exposure just through electronic media, TV, movies, pictures. That generally doesn't count. Unless viewing that kind of material is part of your job, like maybe an investigator who has to review footage.
Why is that line drawn there? Why is seeing something horrific on the news different from being an EMT at the scene?
It seems to boil down to the perceived level of personal threat and the directness of the experience. While media exposure can be upsetting, profoundly so even, it usually lacks that immediate sense of this could happen to me right now, or the sort of professional responsibility that comes with being directly involved or handling the aftermath.
Got it. Okay, so once criterion A is met, we look at the symptoms themselves, which fall into 4 clusters.
Yeah.
B, C, D, and E.
Right. And this is where you really see the heterogeneity of PTSD. People can have very different symptom combinations, but still meet the criteria.
Okay, let's break them down. Cluster B.
Cluster B is intrusion symptoms. This is the reliving part we talked about.
Yep.
You only need 1 symptom from this list.
Only 1. Okay.
Yep. So this includes recurrent upsetting memories that just pop into your head, distressing dreams about the event, and dissociative reactions, what people often call flashbacks.
Where it feels like the trauma is happening all over again.
Exactly. The person feels or even acts as if it's recurring. In the most extreme form, they might completely lose touch with their present surroundings.
Wow. Okay, cluster C.
Cluster C is avoidance. This is all about the effort to push the trauma away. You need at least one of the 2 types of avoidance here.
2 types.
Yeah, first, avoiding internal reminders, thoughts, feelings, memories connected to the trauma. Try not to think about it.
Okay.
And the second,
avoiding external reminders. So that means people, places, conversations, activities, objects, situations, anything that might trigger those distressing memories or feelings.
and the text links this to conditioning, right? Like learning to avoid threats.
Absolutely. It's threat avoidance learned during the trauma. But the problem is, it can generalize inappropriately. You might start by avoiding the specific street where something happened.
Right.
Then maybe you avoid the whole neighborhood. And eventually you might avoid leaving the house much at all because the outside world feels too unpredictable. It can really shrink someone's life.
Yeah, I can see that. Now, cluster D is interesting because it was actually added in DSM-5, negative alterations in cognitions and mood. Why the separate cluster? That's a great question. It reflects the realization that PTSD isn't just about fear and avoidance. It fundamentally changes how people think about themselves, others, and the world, and also their ability to feel positive emotions.
So it captures that deeper shift. How many symptoms do you need here?
You need at least 2 from a list of 7. This covers a lot of ground. Things like being unable to remember important aspects of the trauma-dissociative amnesia,
Okay.
persistent and exaggerated negative beliefs like I'm fundamentally broken, or the world is completely dangerous, or no one can be trusted.
Those sound really pervasive.
They are. It also includes distorted thoughts about the cause or consequences of the trauma, often leading to blaming oneself or others inappropriately. Then there are feelings of detachment or estrangement from other people.
Feeling cut off.
Exactly. And finally, a markedly diminished interest in significant activities or the inability to experience positive emotions, joy, love, satisfaction, what we call anhedonia. The text notes this cluster kind of connects to older ideas like the loss and grief analogy for trauma's impact.
It's like a loss of faith in the world or oneself. Okay, that makes sense. Last cluster. E, alterations in arousal and reactivity.
Yep, cluster E. You need at least 2 symptoms here. These reflect that the person's nervous system is basically stuck in overdrive.
Like the fight or flight system is constantly on.
Pretty much. So this includes things like hypervigilance, constantly scanning the environment for danger, even when you're safe. It's exhausting.
I bet.
Also, an exaggerated startle response, jumping at loud noises, much more than usual. Problems with concentration, sleep disturbance, trouble falling asleep, staying asleep, or having restless sleep.
And irritable behavior.
Yes, irritable behavior and angry outbursts, often with little or no provocation. These arousal symptoms are interesting because they aren't necessarily directly linked to the content of the memory, like a flashback is. They're more about the body's ongoing state of high alert.
Okay, so you need symptoms from these clusters plus criterion A. What else is required for the diagnosis?
2 more key things, duration and distress. The symptoms from clusters B, C, D, and E have to last for more than 1 month.
More than a month. Okay. And they have to cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. It has to actually be messing up your life.
Right, it can't just be a fleeting reaction. And the text also mentions specifiers.
It does. 2 important ones are the dissociative subtype, where the person experiences prominent symptoms of depersonalization, feeling detached from oneself, or derealization, feeling like the world isn't real.
Okay.
And the delayed expression specifier. This is for cases where the full diagnostic criteria aren't met until at least 6 months after the trauma, though some symptoms might have appeared earlier.
So the onset isn't always immediate. That's complex. It makes you wonder how this diagnosis even came about. The text talks about the history, doesn't it?
It does, and it's fascinating. This syndrome has been observed for centuries, under different names.
Okay.
During the American Civil War, they talked about stragglers or soldier's heart.
World War I brought terms like shell shock, which initially implied, actual physical damage to the brain from explosions. Later, war neurosis.
And World War II.
In World War II, it was often called combat fatigue or combat exhaustion. Interestingly, that framing sometimes viewed it almost as a normal, maybe temporary reaction to extreme stress, not necessarily a persistent disorder.
But the really shocking thing, historically speaking, is the Vietnam War era.
Absolutely. You had this incredibly prolonged, intense conflict, widespread psychological distress among veterans, and yet the official psychiatric manual at the time, DSM-II, had no specific category for this kind of trauma reaction.
That seems like a huge gap.
It was a massive gap, and that absence, combined with the advocacy of veterans groups and growing awareness from starting survivors of things like rape and other civilian traumas, really pushed the field.
So that led to DSM-III in 1980.
Exactly. PTSD was formally introduced in DSM-III. It was based heavily on clinical observation, particularly of Vietnam vets and assault survivors. It originally had just 3 clusters: re-experiencing, avoidance numbing, and hyperarousal. It wasn't perfectly defined by research yet, but its inclusion was a landmark moment. It validated the suffering.
Okay, so the trauma is the trigger, criterion A, but we know not everyone who experiences a criterion A event develops PTSD. Why is that? What makes some people more vulnerable?
That's the million-dollar question, really. The text is very clear. Trauma is necessary, but it's not sufficient. It doesn't fully explain who gets PTSD. It's definitely multi-causal.
So what factors increase the risk?
Well, large meta-analyses have identified several key risk factors.
Hmm.
Female gender consistently shows up as a risk factor. Having a history of prior trauma, especially childhood abuse, is a big one.
Okay.
The severity of the trauma matters, particularly the person's perceived threat to life during the event, how scared they felt. And critically, low social support after the trauma significantly increases risk.
So having good support can be protective. What about the biology? The source goes into the neurobiology, the fear conditioning model.
It does. The basic idea is that PTSD can be seen as a kind of maladaptive learning or maybe a failure of recovery after learning. It focuses on fear conditioning theory.
Can you break that down simply?
Sure. So the traumatic event itself is like a powerful, unconditioned stimulus, UCS, that produces an intense fear response, UCR. Later on, things associated with the trauma sites, sounds, smells, even thoughts become conditioned stimuli, CS.
And those trigger the reaction again.
Exactly. Those conditioned stimuli now elicit the conditioned response, CR. The fear, the anxiety, the flashbacks, the avoidance, even when there's no actual danger present.
And specific brain areas are involved in this.
Yes. The core circuit involves the amygdala, which is like our brain's threat detector. It becomes hyperreactive. And crucially, the prefrontal cortex, or PFC, which normally helps regulate the amygdala and provides context, telling it, hey, the danger's over now, seems to have reduced inhibitory control.
So the brakes aren't working properly.
That's a good way to put it. The text frames PTSD not just as a response to injury, but as a disorder of recovery. There's a failure to extinguish the conditioned fear response.
The brain doesn't update the context from danger to safe.
Precisely. It's stuck in that threat response mode. And you see physiological evidence for this too. In the HPA axis, the body's main stress response system.
How does that show up?
It's a bit complex, but often involves things like blunted cortisol responses, which is maybe counterintuitive, but alongside exaggerated noradrenergic signaling. Basically, an overdrive of adrenaline-like neurochemicals.
And that links to the symptoms.
Directly. That hyperarousal state contributes significantly to the cluster E symptoms we talked about. The fragmented sleep, the nightmares, the jumpiness, that constant feeling of being on.
Okay, that provides a powerful framework. Given this persistent fear loop, let's talk treatment. The source discusses evidence-based psychological therapies for chronic PTSD. What are the main ones?
The heavy hitters, the ones with the most evidence, are generally trauma-focused psychotherapies. 3 main types are highlighted.
Okay. First, trauma-focused cognitive behavioral therapy, DFCBT. A core component here is exposure carefully and repeatedly engaging with the traumatic memories, often through imaginal exposure, like recounting the event, and also confronting avoided situations or reminders in real life, which is called in vivo exposure.
Okay, TFCBT. What else?
Second, cognitive processing therapy, CPT. This one really zooms in on the thoughts and beliefs, those negative cognitions from cluster D. It helps people identify and challenge unhelpful thoughts about the trauma, like self-blame or the idea that the world is entirely dangerous.
So it targets those stuck points.
Exactly. And third, there's eye movement desensitization and reprocessing, EMDR. This involves having the person recall distressing images or memories while engaging in specific bilateral sensory input, like side-to-side eye movements or tapping.
Those are the main psychological approaches, but the text mentions a challenge, doesn't it? High dropout rates. It does. That's a significant issue in practice. These trauma-focused therapies, while effective for those who complete them, can be very difficult and distressing. A fair number of people find it too overwhelming and drop out.
Which leads to that provocative question the source raises. Is exposure actually necessary?
It's a really important question the field is grappling with. If exposure is so hard that many people can't tolerate it, is it always the best first step? Some research suggests other therapies, maybe less directly confrontational ones like interpersonal therapy, can also be effective, perhaps by strengthening coping skills and support networks first. It suggests maybe a one-size-fits-all exposure model isn't right for everyone.
That makes sense. What about medications? What does the evidence support pharmacologically?
For medications, the first-line choices, the ones with the most robust evidence and FDA approval specifically for PTSD, are the SSRIs, selective serotonin reuptake inhibitors, specifically sertraline and paroxetine.
Okay, SSRIs first line. Anything else notable?
Yes, for targeting specific symptoms, particularly nightmares, which can be incredibly disruptive, the medication prazosin has shown good efficacy. It's an alpha-1 adrenergic antagonist,
Yeah.
basically working on that noradrenergic overdrive system.
Got it. Now,
Yeah.
there's a big warning in the text about a class of drugs often used for anxiety, right?
Right.
Benzodiazepines.
Yes, a very strong caution. Benzodiazepines, drugs like Valium, Xanax, Ativan, are generally not recommended for treating PTSD.
Why not? They reduce anxiety, don't they?
They can provide short-term relief from anxiety, yes, but the evidence suggests they might actually hinder long-term recovery. The thinking is that they interfere with that crucial process of extinction, learning the brain's ability to learn that the triggers are now safe. They dampen the fear response temporarily, but they might prevent the person from actually learning they don't need to be afraid anymore.
Wow, that's critical information. So avoid benzos if possible. What about preventing PTSD? Can we intervene early, right after a trauma?
This is another area with important nuances. First, let's talk about what not to do. Routine, single-session, psychological debriefing for everyone exposed to a trauma. This used to be very common practice.
I remember hearing about that.
Yeah, but guidelines now strongly recommend against its routine use. Research found it wasn't generally beneficial and, in some cases, might even be harmful or interfere with natural recovery processes.
So don't just rush in with debriefing for everyone. What is recommended?
Early intervention with therapies like CBT can be helpful, but the evidence suggests it's most efficient and beneficial for individuals who already meet the criteria for acute stress disorder shortly after the trauma. Not necessarily for everyone who is exposed, but is coping reasonably well.
So it's more targeted. Any preventative medications?
The evidence here is pretty limited. Only hydrocortisone, a corticosteroid, shows some moderate evidence for potentially reducing the risk of developing PTSD, possibly by affecting memory consolidation or facilitating extinction. But things like propranolol, a beta blocker that reduces the physical symptoms of anxiety, haven't panned out in studies for actually preventing PTSD itself, even if they calm the immediate physiological response.
Interesting. Okay, one last crucial point before we wrap up. Comorbidity. PTSD rarely travels alone, does it?
Almost never, it seems. The source cites staggering lifetime comorbidity rates, somewhere between 80% and even up to 98% with other mental health conditions.
Wow, 80 to 98%. What are the common ones?
Major depressive disorder is very common. Substance use disorders, particularly alcohol use disorder, are frequent. Anxiety disorders, too.
What does this mean for treatment?
It means clinicians have to be really careful with assessment and prioritizing. Often, the most immediately life-threatening issues like active suicidal thoughts, severe substance abuse, or maybe dangerously impulsive behavior need to be stabilized first, or at least addressed concurrently. Trying to do intensive trauma therapy while someone is, say, actively misusing alcohol is usually not effective.
That makes practical sense. Looking ahead, the text mentions the field is moving towards, was it, subtyping and precision medicine?
Exactly. Given how diverse PTSD presentations are, some people are more hyperaroused, others more dissociative or numb, and the fact that it's clearly multi-causal with genetic and environmental factors interacting, the idea of a single PTSD treatment doesn't really fit.
So the future is more personalized.
That's the hope. The goal is to better map these individual trauma pathways. Why does this person develop this specific cluster of symptoms? If we can understand the unique biological, psychological, and social factors for each individual, maybe we can develop more targeted, stratified treatments that work better and faster.
So we've journeyed through the definition and the DSM-V criteria for PTSD, explored its history from shell shock to today's understanding, touched on the neurobiology, that failure of fear extinction, and covered the current landscape of treatments and prevention, highlighting that huge issue of heterogeneity.
Which brings us to a final thought, really building on that idea of personalized approaches. If PTSD is so varied, influenced by genetics, biology, past experiences, social support, and we see different people responding best to different therapies, how might mapping these unique individual trauma pathways change things? Not just for PTSD, but maybe for how we approach all stress-related mental health conditions. It really points towards a future beyond broad diagnostic labels, towards truly personalized mental health care.
A powerful thought to end on. Thank you for joining us for this deep dive into the psychiatric understanding of PTSD based on the source material. We hope this was informative, and we look forward to exploring more foundational concepts with you next time.